Started. So
I'm sharing. I don't think you're sharing.
welcome everyone.
And then you just
Second Journal Club. So today, before I start, I'd like to acknowledge the traditional custodian on the lands on which we are meeting today. So I'm on Camarago land, 65,000 years of culture, one of the oldest in the world. I'd like to pay my respect to the elders past, present and emerging, and recognize the very deep connections to land, sea and sky. So our second journal club is hosted by the Queensland team, Natacha and Ewing, for the Queensland Children's Hospital. So we have two presenters. Each one will go for about 20 minutes. We'll have discussion at the end. Feel free to use the chat to put in your questions or comments during the presentation. So I'll hand over to you now, Natacha and Ewing.
Thank you, Angela. So as Angela has already said, we have Nicol, one of our Paediatric Oncology fellows, who is going to start with presenting on the recent publication from the French group on high-risk Ewing sarcoma and their quite good results, actually, with their clinical phase 2 trial. So it might be of interest to everyone working in the field in pediatric AYA, Ewing sarcoma. Thanks so much, Emma, for presenting. I think you're muted. Oh, sorry.
Good girl, good girl.
Hello, can you hear me?
Yes.
So, thank you, Natasha. Today I'll be discussing the paper recently published by Lawrence et al. In the British Journal of Cancer, entitled Interest of a Sequential Multimodal Approach for the Treatment of Newly Diagnosed Patients with Multimetastatic Ewing Sarcoma, the results of the French prospective Combinate R3 phase 2 trial. So the Combinate R3 phase 2 trial was run across 15 French centres between 2017 and 2021 and explored a sequential approach with induction chemotherapy, local control, high-dose chemotherapy-based consolidation therapy and a prolonged maintenance therapy in 42 newly diagnosed patients with extrapulmonary disseminated Ewing sarcoma. The primary endpoints that they were explored were event-free survival and overall survival, and their reported outcomes included a 3-year event-free survival of 53.7% and a 3-year overall survival of 65.5%, which compared to previously reported 3-year overall survival in the range of 13% for this cohort. A secondary objective also evaluated the use of liquid biopsy with detection of circulating tumour DNA as a monitoring adjunct, which showed promise as well. However, limitations to this study include that it was not randomised, there was selection bias, they only evaluated the sequential approach rather than individual components of the treatment approach, and there were low patient numbers. So today I aim to cover a little bit of background of the current standard approaches to extrapulmonary metastatic Ewing sarcoma, as well as the background and rationale to the proposed approach in the Combinate R3 trial, then the trial methods and results and some contributing factors to their reported outcomes. Then finally, some thoughts on how these results could be incorporated into our practice and further clinical trials. So as we know, Ewing sarcoma is a rare tumour with peak incidence in the second decade of life, and with diagnosis characterised by translocation involving the EWSR1 genes in most cases. In 25% of cases, staging procedures detect metastatic tumour at diagnosis, most commonly involving the lungs, followed by bones, bone marrow and other sites such as lymph nodes. Primary metastatic dissemination is one of the most important prognostic factors in Ewing sarcoma, with survival rates of 70 to 75% in localised tumours, compared to less than 50% survival with those with primary metastatic disease. Among those with primary metastatic disease, bone and/or bone marrow involvement significantly worsen the prognosis, defining a group of very high-risk patients with frequent relapse and poor overall survival, previously reported in the realm of 0 to 30%. The current standard treatment approaches for Ewing sarcoma combines primary chemotherapy with regimens typically based on alkylating agents, etoposide, anthracyclines, and vincristine, followed by local control, including surgery plus radiotherapy, and then subsequently followed by consolidation chemotherapy, sometimes with high-dose chemotherapy and stem cell rescue. The majority of paediatric Australian centres currently following the Ewing 1 protocol, which outlines an approach to treatment of newly diagnosed Ewing sarcoma, including both localised and metastatic disease, with a interval compressed BDC-IE induction therapy with 9 alternating cycles of BDC and IE at 14-day intervals, followed by local control of surgery and or radiotherapy, and assessment of response to induction, and then consolidation therapy with either VC-IE consolidation or, in some cases, busulfan, melphalan, high-dose chemotherapy with reinfusion of autologous stem cells. These recommendations for induction and consolidation therapy are based on the findings of the COG AEWS 0031 randomised controlled trial of interval compressed chemotherapy, alternating the VDC and IE every 2 weeks rather than every 3 weeks, which was published in 2012, as well as the Ewing 2012 randomised study with results published in 2022, which demonstrated superiority in terms of both efficacy and toxicity of this interval compressed induction chemotherapy, followed by IE, VC or butanol consolidation for all stages of newly diagnosed Ewing sarcoma, compared to previously used regimens with VIDE induction. VDC-IE is therefore now the standard backbone chemotherapy in all Ewing sarcoma. And currently this approach is standardised for both localised and metastatic disease at diagnosis. However, there's significantly different outcomes between these two cohorts. Specific to disseminated Ewing sarcoma, there's relative paucity of literature, with studies to date mainly based on retrospective studies or prospective non-randomised studies. This brings me to the approach that was proposed by the study group in the Combinate R3 trial, which aimed to evaluate a sequential strategy combining dose-dense induction with a mid-induction reassessment and a chemotherapy switch if there was an inadequate response to the initial chemotherapy, followed by high-dose chemotherapy-based consolidation with the timing of local control either before or after high-dose chemotherapy, and finally a prolonged maintenance therapy stage of 2 years. So this is the figure from the paper that outlines the treatment approach. So in this panel B at the bottom, it shows the induction dose-intensified VDC-IE chemotherapy, initially with 4 cycles alternating VDC and IE, which is the same as the current standard approach, but at the time was only based on the results of the AEWS 0031 trial. If an adequate response was achieved after 4 cycles of VDC-IE, defined as response of both primary tumour and metastatic sites, then they proceeded with further 4 cycles of VDC-IE. In cases, however, of an incomplete early response with either stable or progressive disease in either the primary tumour or metastatic sites, then induction chemotherapy was switched to subsequent 4 courses of temozolomide irinotecan-based chemotherapy instead of the VDC-IE. This dual approach, combining the backbone VDC-IE with a response-based change to temozolomide irinotecan, aimed to improve the quality of the initial response at the end of induction therapy, and thereby increase the number of patients eligible to proceed to high-dose BMEL consolidation therapy by reducing residual tumour burden and thereby reducing the need for early radiation to central sites, which precluded patients from busulfan-containing dose chemotherapy for reasons of anticipated toxicity. Following induction, they then recommended local therapy, which the approach to which was determined by the investigators rather than specified specifically by the trial. And it could occur before or after high-dose chemotherapy consolidation as appropriate. Surgery was performed wherever feasible, and radiation therapy was applied to inoperable tumours or used in conjunction with surgery for those that had high-risk features such as incomplete resection, poor response to induction, or unfavourable tumour locations. Local management of metastatic lesions was also included for any patients with less than 5 metastases in total. The next step was consolidation chemotherapy, and the COMBINE-AR3 trial proposed a consolidation based on high-dose chemotherapy with busulfan and melphalan, followed by autologous stem cell transplantation for patients, but only for patients who had an adequate response to induction chemotherapy, and no contraindications related to the need for primary tumour radiotherapy. Patients who failed to meet criteria for an adequate response were classified as non-responders and discontinued treatment in the study. Finally, maintenance therapy in the trial proposed a 2-year maintenance regimen combining oral daily cyclophosphamide and weekly IV vinblastine plus or minus daily celecoxib during the first year, and the second year was only daily cyclophosphamide. And this approach was inspired by the maintenance regimen used in the Ewing Paediatric soft tissue sarcoma study group RMS 2005 trial in high-risk rhabdomyosarcoma, which subsequently has published positive results confirming the survival benefit of low-dose cyclophosphamide as a maintenance chemotherapy for patients with high-risk rhabdomyosarcoma just in June last year. So the methods used in this trial, so it was a phase 2 non-randomised clinical trial, and eligibility criteria included any paediatric or adult patients aged 2 to 50 years. The diagnosis had to be confirmed by presence of tumour cells harbouring positive EWS FISH rearrangements. Baseline assessment was as standard with primary tumour imaging, metastatic site evaluation, and whole body PET-CT. Metastatic patients were only eligible if they had measurable or evaluable disease and by RECIST criteria. And they also had to be deemed able to proceed with both local treatment, in particular radiotherapy at the primary site, without contraindicating busulfan-based high-dose chemotherapy. The primary endpoints explored were event-free survival and overall survival. However, they also incorporated an exploratory endpoint, the use of liquid biopsy and detection of circulating tumour DNA as a marker of treatment response and disease progression through correlation with well-established PET-CT imaging data. The cohort characteristics in this study were reflective of other similar studies of metastatic Ewing sarcoma. They were able to enrol 45 patients, but only 42 were analysed, as 3 patients were not eligible after further investigation. There was a male-to-female ratio of 2 to 1, with a median age of 14 years, but ranging from 6 to 47 years, with the majority being under 25 years, 92% of patients. 85% had classical EWS-R1 rearrangements, with one having an atypical zinc finger domain containing fusion, and 4 cases had unknown EWS-R1 partners for the translocation. Most common tumour location was bone in 83%, with the remainder being in soft tissues, and the pelvis was the most common primary site in 42% of cases. Of those who did have bone or bone marrow involvement, 51% exhibited more than 5 bony lesions, metastatic lesions at diagnosis. So the flow through the study and the number of patients who were able to complete the study protocol, of the initial 42 patients who began induction therapy, there was exit of 9 patients, such that 33 were able to commence high-dose chemotherapy. And of note, at the mid-induction reassessment time point, 4 patients changed from the BDC-IE to temozolomide irinotecan-based therapy. either due to inadequate response or in one case due to physician decision. So ultimately, 33 patients proceeded to high-dose chemotherapy after that inadequate response. And of note, all 4 of those patients who had been changed to the temozolomide and irinotecan did proceed to high-dose chemotherapy, despite that initial inadequate response. They had subsequently had a further adequate response enabling them to proceed. 29 patients then commenced chemotherapy. However, 9 patients exited due to disease progression, leaving a final 20 patients who completed the entire protocol. Regarding the local treatment, among the 33 patients with adequate response to induction, 31 received local treatment, and this included surgery alone in 7 patients, definitive radiotherapy in 16, or a combination of the 2 in 8 patients. So the primary endpoint results reported were event-free survival, defined as a time from inclusion to the first event or last follow-up. Median follow-up was 47.6 months, and a median event-free survival was 42 months, with an 18-month event-free survival of 63% and a 3-year event-free survival of 57%. 18-month overall survival was 75% and 3-year overall survival was 65%. Total of 15 patients died due to progression of the tumour during the study. So the factors that they identified in this study that influenced the event-free survival and overall survival included the primary tumour volume being greater than 200 mils as a significant negative prognostic factor for event-free survival. Similarly, bone marrow involvement at diagnosis also showed a trend towards worse than event-free survival, significantly associated with poor survival. There was no significant impact on survival from the age of the patient, the type of extra osteomedullary mets, or a Leidenstone score. However, they were unable to draw meaningful conclusions on the impact of the choice and outcomes of local treatment on survival due to the limited sample size in each of the subgroups of surgery, radiation, or combination of the 2. And toxicity throughout the trial was as expected based on the agents that were used. Regarding the exploratory endpoint of the circulating tumour DNA, these results were quite interesting in that all in that 34 of the 42 patients were profiled at baseline, and all 34 were ctDNA positive by fusion detection or copy number variant analysis at diagnosis. Subsequently, at all time points, negative PET-CT findings correlated with an absence of ctDNA on liquid biopsies. And all liquid biopsies that were collected at progression or relapse, which was 12 samples in total, were positive for ctDNA. And 2 of these had detectable ctDNA prior to any other signs of relapse, either symptomatically or on imaging. So the study conclusions presented in this paper were based on the statistical analysis assessing treatment efficacy compared to the Ewing 99 reference cohort, which reported a median event-free survival of 13 and an overall survival of 30%. Using this comparison, the multimodal strategy evaluated in this trial could be considered potentially effective with a p-value of less than 0.01. And they concluded that this supports the proposed strategy as a first-line option for selected patients with very high Ewing sarcoma. Delving into, however, what contributed to these outcomes, then it becomes difficult to discern exactly what was where the benefit came from. In the Ewing 99 reference cohort, they used a VIDE backbone plus 1 cycle of VAI and local treatment, and then a BU-MEL high-dose chemotherapy with no maintenance therapy. Since this trial, the VDC-IE backbone superiority has been established, and is now standard of care. And in addition, the use of the VDCIE plus or minus switch to temozolomide irinotecan at mid-induction may have contributed to a higher proportion of patients achieving a favourable response at the end of induction, and thereby an improved number of patients being eligible for the high-dose chemotherapy consolidation. And this is reflected in the COMBINE-AR3 trial. 78.6% of patients were able to proceed to high-dose chemotherapy, whereas only 60% in the Ewing trial. Compared to the Ewing as well, the COMBINE-AR3 approach incorporated the maintenance therapy. So all or some of these could have contributed to the significant improvement in outcomes that was reported in the study. So the limitations of the study. Firstly, there was a degree of selection bias in that only patients who were deemed at the outset to be able to undergo both local therapy and busulfan-based high-dose chemotherapy were eligible for inclusion in the trial. There were also quite low patient numbers overall. They've calculated a sample size of 45 to achieve sufficient power for statistical analysis, but only 42 patients of 42 of the 45 enrolled patients were actually eligible for the trial after the initial misdiagnosis and non-metastatic disease. The median follow-up period of 48 months was too short overall to completely exclude possibility of late recurrences. However, fast relapses tend to occur within a shorter time frame, reported in other studies. So whether or not that has too much impact on the study is clear. It's also difficult to determine which components, as I've already discussed, of this regimen contributed most to improved patient outcomes, as they were analysing an overall sequential approach rather than various components of the treatment regimen. And finally, the use of the switch of the quite novel approach with a switch at mid-induction to temozolomide and irinotecan was unable to be thoroughly assessed, as there was only limited patient numbers whom this applied to, with only 4 of the initial 42 patients undergoing this switch. So overall, though, the study does have some really encouraging results for improved survival. However, a subset still exhibited poor prognosis, underscoring the work that is still needed to be done in this area to improve outcomes. One such approach is strategies incorporating tyrosine kinase inhibitors, in particular regorafenib, into the treatment approach for Ewing sarcoma. And there's several randomised control trials currently underway exploring this, including the REGO into Ewing 1, and the REGO main studies. In addition, there's need to further assess the individual components of the sequential approach, including further exploration of the mid-induction switch to temozolomide or irinotecan or other agents, the use of choice of chemotherapy used in the consolidation between the BCIE approach and the high-dose chemotherapy approach, and finally, the addition of maintenance therapy, which is already under investigation through the Ewing 1 trial, with the randomised C arm currently open to recruitment, exploring the addition of maintenance therapy for vinorelbine and cyclophosphamide at the end of consolidation therapy in a randomised control trial compared to no maintenance therapy. And finally, further validation of the use of circulating tumour DNA to identify poorer prognosis in cases of slow response to induction therapy, or to be used as a method of disease surveillance through reliable detection of ctDNA to relapse. To validate this further, baseline ctDNA detection could confirm whether the assay was likely to be reliable for a given patient, and potentially warrant use of ctDNA monitoring throughout follow-up, thereby contributing to a reduction in the need for frequency of CT imaging as a method of surveillance for ongoing surveillance.
So can you just escape
So, of course.
Go to the group and questions. Thanks, Emma. That was great. So we'll open it up to the floor for questions or comments. And if you could just put your hand up so I can do it in order, that would be helpful. Can't see any hands. Natacha, did you? Oh, here we go. Vivek's got a question. Go ahead.
Hi, that was very nice to present it. Thank you very much. So you talked about, which of the components of this sequential approach are likely to have contributed to the better survival outcomes seen in this study. But what do you think out of all of those do you think is the probably the key driver of this improved outcome? Whether do you think it's the switch, or do you think it's the maintenance, or do you think it's something else altogether?
And start with what I think it's not, and that's I don't think the switch there's definitely not enough data for the switch, the mid-induction switch to support, with only 4 patients requiring that switch mid-induction. I do think there is the fact that such a larger proportion of patients were able to complete induction therapy and that with an adequate response and therefore proceed to the high dose consolidation is likely contributing as well. But then if you look at the number of patients that start maintenance therapy and then are still within the study at the end of maintenance therapy, it does show, with 29 patients and then 20 patients at the end, I think we're still able to complete maintenance therapy. That's quite a high proportion who didn't relapse during the 2-year period, which I think is really representative of the benefit of the maintenance therapy.
Personally, I think the maintenance therapy is going to be very important here. Yeah.
Yeah, I think so too. But I mean, one of the things that Emma pointed out as a limitation is the short follow-up. And I guess if you keep people on chemotherapy long enough, you may extend their eventual survival. The question is, does it make a long-term impact and not significantly add to toxicity? But we're talking about a population that traditionally just die anyway. So, a 30% is a very optimistic survival figure for bone and bone marrow patients. Paediatric, nice to see you.
Thanks. Look, I was quite interested in this because I've got 2 patients diagnosed on the same day, 2 young girls with widely metastatic Ewing sarcoma. And I told our transplant team to attend to convince them that, do you think collecting stem cells of 1 block of iron is good? And what do people think? Like, should it be offered? Because the previous trial showed that in metastatic patients, high-dose chemotherapy did not make a difference. It made a difference in patients who had that sort of large local tumors. In those groups, it made a difference. So do we all think it's convincing, and should it be offered to young patients who respond well to initial therapy? They mostly, our experience is they respond well for some time and then they don't.
Yeah. I guess if you're offering a whole package, it seems reasonable to me, Bhavna. Like, you can't just say, we'll do your stem cell transplant and then stop there. That seems to be one of the messages. And then, of course, it'll be intriguing to know whether or not, and presumably you're going to offer them the Ewing trial, because I think that's an important question as well, to answer whether one of those TKIs will make a difference. And our early observations suggest that it may be helpful, but we need to do the trial, we need to complete the trial. But I don't have the answer. But I don't think it's unreasonable to ask for a harvest at least.
Yep.
Jess, nice to see you.
And you too, Wayne. Thank you for a great presentation. And yeah, I'm also really highly encouraged by this data. I would agree the follow-up was short, but most of our metastatic Ewing's patients will relapse within that first 2 years. So whilst it's a short follow-up, I still think it's probably quite representative. I'm really impressed that half the patients got all the way through that treatment protocol and completed 2 years enrollment. So
Yeah.
I think, and Bhavna, you know, we've spoken about your two patients. I think particularly in those two patients that you're talking about, they don't have pulmonary mets. So that's, I think giving them a BUMEL consolidation is actually a really good option for those two patients and doing the maintenance. Because I will say this is one of the most encouraging publications I've seen in metastatic Ewing's in some time.
Yeah, I was interested that I think there was like 20, there was quite at least 20 patients with chest primaries, but they were still eligible for a BUMEL transplant. That was interesting. But anyway, clearly they decided that that was okay. They could at least save one lung, as it were, because we traditionally don't like BUMEL with busulfan with anybody getting chest radiation.
And can I ask one more question? Do people routinely do bone marrow in metastatic Ewing sarcoma to assess bone marrow disease?
Imogen will answer that question.
That's one of the ancillary questions of inter-Ewing 1.
I know.
They're trying to correlate bone marrow aspirate with PET imaging, because there are a few publications, like you said, not in favor of testing it if it's negative.
I know. It's constant battle. But anyways, all right.
Oh, Marianne. Hello, nice to see you.
We can't hear you, Marianne.
I knew I'd get a reception from you, Wayne. I just was going to drop it in there from an old person that we all would for metastatic until the results of the studies are out. We still do bilateral marrows and trifines. And yes, we offer a rainy day collect to all metastatic patients up front, albeit the evidence for megatherapy remains limited. We do collect them because some patients, regardless of this study, do relapse, and some of those patients remain chemosensitive and are salvageable, and in relapse we would then offer a megatherapy. So we answering Bhavna's question, do you collect? We collect all of our metastatic patients up front, and we call it a rainy day collect, and then we decide when we're going to use it.
Including just your pulmonary only patients, Marianne?
Yeah.
Okay. Cool.
Just so that it's done, because the more chemo that you give, obviously, the more difficult it becomes to collect. And the regimens used to collect after become perhaps less predictable. So it's just a comment from an old person.
Well, nice to see you. We'll move on to the next.
I'll just make a small note, sorry, Wayne, just to advertise for the ANZSA work. We have done a systematic review with the ANZSA working guidelines party on high-dose chemotherapy in Ewing sarcoma and rhabdomyosarcoma. So if you're interested in seeing the evidence that we've collected in our systematic review with the 29 publications on the subject, I guess, there is a bit more details on this. Obviously, this study wasn't included because it wasn't published yet when we published a review last year. But yeah, just if you want to refer to it. But yes, unfortunately, not much evidence for high dose in those high-risk patients before this publication was out.
Yeah. And Natacha is completely right. So that's why I emphasize we do it as a rainy day collect, and we would often then use it after a relapse.
And thank you, Angela, for the link. So I'd like to introduce Dr. Imogen Andrews. She's our Queensland Youth Cancer Service Fellow and is also working with Zero. And she's going to present an interesting article on that old chestnut Mifamurtide.
I'll just check that everyone can see the slides. So I'm one of the Queensland Youth Cancer Service Fellows, and this evening I'll be discussing the 2025 paper from ASCO, which reviewed the role of Mifamurtide in non-metastatic high-grade osteosarcoma and combined results from 2 European trials from Spain and Italy. So the use of Mifamurtide in osteosarcoma has remained controversial over the years and has been inconsistently adopted globally following on from these earlier trials. It's been a recent discussion point in our local team, so I hope it provides some ongoing discussion this evening. So as we know, osteosarcoma is the most common type of primary blood malignancy we see in children and adolescents, and complete resection of detectable tumours is important for long-term survival. Whilst we've seen significant improvement in survival outcomes from the introduction of neoadjuvant and multi-agent chemotherapy, the 5-year overall survival for children and adolescents has plateaued over recent years, with 5-year survival rates in localised osteosarcoma sitting around 60 to 70%. Mifamurtide, or MIPACT, is an immunomodulatory agent which activates macrophages and stimulates the release of pro-inflammatory cytokines and is thought to increase the tumour immune response. Previous studies, including the intergroup study 0133, suggested that there was a potential survival benefit with MIPACT. However, this paper has been previously debated and the uptake of mifamurtide in osteosarcoma patients worldwide varies, with approval in Europe. However, notably, it remains not approved in the US and, to my knowledge, is not commonly used in Australian centres. So the question really remains, does mifamurtide truly improve outcomes, and should it be considered for use in our osteosarcoma patients? So this recently published 2025 paper aims to assess whether adding mifamurtide improves outcomes in patients with non-metastatic, so localised high-grade osteosarcoma. This paper was a combined analysis of 2 trials, a phase 2 trial from the Italian sarcoma group and an observational cohort study from the Spanish sarcoma group. Importantly, neither of these were randomised comparisons of mifamurtide versus no mifamurtide. They had very similar inclusion and exclusion criteria, including the patients needed to have primary high-grade osteosarcoma at the extremities with localised disease. They needed to have not had prior chemotherapy or surgery. And in the Italian group, patients needed to be aged under 40, and in the Spanish group, aged between 2 to 30. Exclusion criteria included those with metastatic disease, and those without survival data were excluded from the final analysis. The study period extended from 2013 to 2018, and the analysed data included 398 patients, ranging from 4 to 40 years, with a median age of 14, with localised extremity osteosarcoma. So this is a relatively large cohort of osteosarcoma, which is a strength given the overall rarity of the disease. Looking at the treatment schema, all patients in the study received standard neoadjuvant MAP chemotherapy, and following the resection of their primary, the patient's post-operative treatment varied based on their histological response and their P-glycoprotein status. The patients with tumour necrosis of greater than 90% or more were classified as good responders, and patients with less than this were classified as poor responders. As a reminder, a P-glycoprotein is an efflux pump and is thought to reduce the tumour concentration of doxorubicin and potentially contribute to chemotherapy resistance in osteosarcoma. The authors of this paper reported on the previously published literature to suggest that PGP status is an unfavourable prognostic factor in osteosarcoma, though the authors did acknowledge that this remains controversial, as there have been some studies to report conflicting results on the strength of this correlation between PGP expression and overall survival in osteosarcoma. As further depicted in this schema, following on from neoadjuvant chemotherapy and surgery, patients who were PGP negative continued MAP chemotherapy as a standard postoperatively. And then patients who were PGP positive with a good response to induction chemotherapy continued the standard MAP, but they hadn't added mifamurtide alongside this therapy. And patients who were PGP positive with poor response to induction chemotherapy actually changed their chemotherapy regime to a cycle of doxorubicin followed by high-dose glufosinamide, and also had mifamurtide running alongside this. So this treatment protocol in itself is quite relevant for discussion, as the comparison is not just mifamurtide versus mifamurtide, but we're looking at different treatment intensities. Primary endpoint was 5-year event-free survival, and this was calculated from the first day of chemotherapy to disease recurrence, whether that be local or distant, death from all causes, secondary tumours, or the last follow-up exam. Overall survival was the secondary endpoint and was calculated from the first day of chemotherapy to death or last follow-up. There were 398 patients analysed, 204 were treated with mifamurtide and 194 were not, and the median follow-up was 70 months. So looking at the results, starting with the unadjusted results, these Kaplan-Meier curves demonstrate that essentially with the EFS, the 5-year EFS was 71.4% in the mifamurtide group and 58.3% in the non-mifamurtide group. And this was statistically significant with log-rank p-values of 0.013. So up front, this looks quite meaningful and there seems to be a separation between these two groups. However, we need to remember that this was the unadjusted comparison and it didn't account for the baseline imbalances for treatment and heterogeneity. So when you look at the multivariable analysis, where they accounted for confounders such as age, tumour characteristics, histologic response, PGP status, and treatment differences, the results to support the benefit of mifamurtide actually don't meet what we would consider conventional statistical significant thresholds, as the p-value was 0.059. So it's not really robust evidence to suggest an independent treatment effect of mifamurtide. Other factors which the study team did look at, which happened to maintain statistical significance in the multivariable analysis, which were associated with worse survival outcomes, were a high serum ALP and poor histological response, which we already know. Looking at the overall study design, there are some key strengths. We've got a really large cohort of patients with 398 patients. Both the Italian and Spanish trials were multi-centre cohorts. The prospective design of these trials improves the data quality and the consistency of the outcome measurement, and the duration of follow-up was adequate with a median 70-month follow-up. As I've alluded to, there are substantial limitations. These trials are non-randomised. There was confounding by indication due to non-random treatment allocation, leading to baseline imbalances between the two groups. The treatment was assigned by clinicians based on their PGP status and histological response. So the reason a patient was allocated to the mifamurtide pathway was because their presumed prognosis was worse. Treatment heterogeneity was also an issue with the PGP group, all receiving mifamurtide, but then receiving different chemotherapy regimes, with some receiving cyclophosphamide. PGP as a biomarker is also questionable, as it's not routinely used in contemporary osteosarcoma risk stratification, though there is literature to suggest it does demonstrate unfavourable prognostication in osteosarcoma.
If I remember rightly, when I looked at the article, there was only a small percentage of patients that actually got tested, though, wasn't it, for PGP? It wasn't 400 patients who got tested.
I'd have to double check, but it was standardised testing, and they were all tested at the same Italian lab. Right. But I'd have to double check on the numbers.
I'll get Natacha to, she'll know that off the top of her head. She can comment on that.
So overall, when we look at this in comparison to the prior evidence and put it in context of some large mifamurtide osteosarcoma trials like the intergroup study 0133, the intergroup reported improved survival outcomes in some mifamurtide containing arms, but these results were inconsistent across the treatment groups, and that's what's contributed to the controversy regarding its benefit in the longer term. And while this current study suggests a potential benefit, given there's that loss of statistical significance on the multivariable analysis, it suggests that these baseline patient differences and treatment differences could be driving the effect that we're seeing. So I'm not sure that it resolves the previous doubt we've had from prior trials. And I think perhaps it should, just continue to the hypothesis generation and not actually change our clinical management at this stage. And that is
Thank you, Imogen. Thank you, Imogen. I guess, so for the PGP question, it was centralized, like you said, Imogen, and it was on immunohistochemistry with 3 different antibodies. So I think it was pretty reliable testing. And all patients were tested that were included in the 2 trials from what I read in the study. So that, I think that was accurately done. But I do agree that, yeah, I'm a bit sad that they did that stratification because it's far from standard in osteosarcoma therapy. And I would have loved those studies to answer the question a bit better of the Mifamurtide, which has probably been, you know, yeah, we're probably a bit confused with that PGP testing and stratification of patients on positivity. Anyway, I'll open the floor to other comments and questions, please.
Excellent. It says,
Jessica?
sorry, just to clarify, it says in the INT 0133 group, they were, that's the original trial, PGP expression analysis was only possible in 139 out of 685 patients. So that was from the earlier study.
Yeah,
so
not from that Spanish and Italian.
Yeah.
Sorry, yes, I think Jess, as for you raise your hand.
Yeah. I'm sorry, I didn't get a chance to read this one before the journal club. Did they say anything about compliance and how many people completed the whole course of Mifamurtide? And I only ask because when I worked in the London Sarcoma service in the UK, Mifamurtide is actually approved for all patients with localized osteosarcoma. And what we observed is with the toxicity, a lot of patients became febrile, and every time they were febrile, they required admission. So we did notice a significant drop-off from patients' uptake of Mifamurtide. So they would all have it while they're on chemo, and then when they were off chemo, most patients abandoned Mifamurtide. Well, a significant proportion, and I don't have the exact numbers, but anecdotally, it was a significant proportion of patients gave up.
Thanks for that question. Yeah, so in this actual paper, they didn't comment on the uptake, but when you go back to the original trial requirements, particularly the Spanish group, they essentially said it was up to clinician discretion whether they were going to start Mifamurtide or stop. So I think, you know, if you went back to given it was an Italian and a Spanish trial combined, I think if you went into them, I wouldn't be surprised if there's a little bit of clinician discretion and patient discretion leading to lack of uptake. But I also, having come from the UK, had a slightly different experience with Mifamurtide, perhaps because it was a paediatric centre. Whilst we did see a lot of fever and needing admission, our patients continued it, but it was a paediatric centre, so I think fever, neutropenia, admissions and compliance is perhaps maybe a little bit better in paediatric centres because families are just conditioned to that's all part and parcel of the treatment process.
Yeah, so I worked in the AYA unit at UCLH. So we had a mix of paediatric and young adult patients. So there was still significant drop-offs, but osteosarcoma is usually in teenagers. So I don't think there'd be a significant difference between paediatric and AYA.
Yeah, that's definitely a good remark. Anyone else?
Is anyone else using it?
Is anyone? Oh, sorry, Wayne. Yeah, go for it.
I'm pretty sure Vivek or people from your centre sometimes use it, don't they?
Yeah, that was my question as well. Who is using it in Australia?
Yeah,
Hi, Vivek.
I used it once in a patient, but not actually in the approved indication. So my patient had actually metastatic osteosarcoma, but we got him into a surgical CR after resection of all his disease. And he actually sought an overseas opinion from, I think it was from someone in the States, who actually recommended that he have Mifamurtide. Now, I wasn't actually planning to give it to him, but him and his family were very pushy, and we managed to get it on compassionate access. So we did not use it in this approved, localized resected osteosarcoma setting, but he tolerated it well, and actually he's still in CR 2 years later. So I'm not sure if it did anything, but that's the only time that I've actually used it. I think the problem with this particular study is it actually doesn't really answer the question, is Mifamurtide going to be helpful, because of all the different ways it's combined and the different populations it's used in, which is a shame, because I think it'd be really good to know once and for all whether this drug is worth actually using or not.
Yeah.
I think there is a SARC study, one of the SARC studies that is studying Mifamurtide prospectively. So we may get that answer in 5 years.
There are a few studies open at the moment. I've just included the capsulate included in this paper, and there's a few, not a lot of them are randomised. I think the MEMOS study is a randomised trial, but not a lot of the rest.
Marianne, you have a comment as well?
It was the subject of a children's cancer group before CCG and POG joined together to become COG. It was the subject of a trial, and I believe the trial closed due to lack of tolerability, but I can't remember. That was in the early 2000s. I think that I had a patient that went to the same person as you, Vivek, in the States, but my patient had been advised that she wasn't curable. She had widely metastatic recurrent disease, and some lady in the States told the family that we were all idiots because we weren't using this drug. So we got it on compassionate grounds and not against our better judgment, and gave it. She tolerated it very well, but it did nothing at all for her disease, predictably enough.
I sort of remember a lady at COG being terribly passionate about it. It might have been her.
I do think, though, that I think it came too early with its age. That's what I feel about this drug, because it came before the whole interest and excitement about immunotherapies. And, it is an immunotherapy. It's an activator, like it kind of suppress the inhibitory macrophage and things. So I think, if you like immunology, I think it's actually a very interesting effect. And maybe if it had come more recently, people would have have had more adhesion to it and how it might work, because it came all before we were very convinced that the immune system had a role in controlling cancer. Maybe that's why it didn't really picked up. That's a feeling I have as well. But anyway, but yeah, it is a shame that the study is not done as well as we would like to make a real conclusion. Where I thought that it could raise my interest and questioning about using it for my own patient was for those patients where we have very poor response to chemotherapy, and they have like terrible necrosis rate, and a lot of the time the question comes up, should we swap them from MAP to something else? And some people do swap them to IE, even though there is absolutely no evidence for that, and there is a randomized trial showing that doesn't make any difference. But yeah, I was wondering, I could think about, should we change to like high dose IFOS and Mifamurtide? I guess that was something I was thinking when the parents are very surprised when we tell them, oh no, he's responded very poorly to chemo, but let's keep doing the same. Vivek, you had a comment?
Yeah, I just wanted to say just one other thing about Mifamurtide is that the drug company, the Australian distributors of this drug are actually, I think, going to be trying to promote the use of Mifamurtide over the coming years. I think the company's just been purchased by another company, something like that, but they're keen to try and get more of us in Australia prescribing this drug. So I think you may be people might be suggesting meetings with the company that is going to be distributing this drug over the near future. So I think they're going to try and make a
ANZSA organisers.
Maybe we should email them.
I think it's the same drug company and same pharmaceutical representative from the Eflorna thing.
Oh, is it Norgine? Is it Norgine?
Yeah, because he mentioned yeah, when I met with him, he said that he asked me about my opinion about Mifamurtide and what I thought about it, and that he's like, "Oh, we're thinking about pursuing it in Australia."
Mm.
Okay, I know that guy. I'll have a chat with him.
Interesting. Okay. Any other comments or questions for the last 5 minutes?
So just a question to the floor. Is actually anybody going to start using it more now, do you think? Or
Well, I did send a paper to my colleagues who had a patient with 0% necrosis. And I was thinking that could be an option. I guess we need to have a chat with our team locally, see what we think about it. But, there is definitely, I think, you know, if you take the initial study, the INT 99 or something, there was definitely some suspicion that actually it interacts better with ifosfamide. So I think that there is an effect in the combination probably that we're missing here in that paper as well. And that's probably why the water is even more unclear. But yeah.
I think it's whether we'll all use it or not. I think there are major equity issues around it because it's so expensive. So your passionate, well-read parents who really push for it will be the ones who get it, and your average person who maybe doesn't have that may not push for it. And I think we as a sarcoma team in Australia have to really make sure we're offering equitable things to everybody. So and then if we do equitably offer Mifamurtide to everybody, it's going to be super expensive.
Yeah, I agree, Jess. And basically my opinion is unless it's free, I wouldn't want to use it at the moment.
Yeah.
Based on the evidence.
And that's what I've said to parents who ask for it. Yeah.
And we can tell the pharmaceutical company to work to put it on the PBS like they have done in Europe.
Yeah, they'll struggle unless they've got champions. It's interesting, people like Ian Lewis, I mean, Marianne will know them, but Ian Lewis, when he came out here many years ago, he said, this is a great drug, we should all be using it, but the evidence still remains sketchy. It's no fool.
I think we'd all love it if it did work. Like I'd be on board.
That's right.
So, you know, have some kind of improvement in osteosarcoma outcomes, I'd be thrilled.
Yeah.
Right. Well, thank you everybody for coming and joining us tonight, and really excellent presentations. Well done, both of you. And thank you everybody. And we look forward to the next one, which is it in June?
Yes, 17th of June. It's going to be hosted by Jason Kane from the Hutchins Medical Research in Melbourne. So hope to see you all. And thank you, Imogen and Emma, for excellent presentation and everyone being so engaged this evening.
Thanks, Angela.
Thank you.
Thank you.
See you all. Bye.
Excellent.